compound in this plant, or the most important cannabinoids that is available and has been studied so far, is tetrahydrocannabinol. So when you see THC, that means this is the most psychoactive substance within or coming from that plant. Okay, it's cannabinoids,
Doctor,
abuse.
can
Yes.
sorry to cut you off. Can the screen be in full mode?
Okay, fine.
Thank you.
Okay. The problem is that I do not see the cursor. حقي ما أعرف ليش. Anyway, do you see that when I'm pointing?
Yes,
No.
doctor, we used to see it before, بس هلا
That's why when I enlarge the screen, it does not show.
Doctor, I don't think you need to put it as a large screen because it's clearly like it's vivid, like we can read it.
Yeah, because I want to point.
Yeah.
Actually, you can open it through Moodle. I think if you access it through Moodle, you can enlarge your screen for your own laptop, if that helps. I think.
Yeah.
Well, I am sharing my screen. You cannot see it. Anyway, so let's go to the cannabinoids. Is it actually a public health issue? According to the WHO, and unfortunately, it says that cannabis use or cannabinoids abuse is the most commonly used illegal psychoactive substance worldwide, and has been estimated that 2.5% of the whole world population, they have actually some history of cannabis use. So 2.5 from the whole world is actually quite big percentage to understand or to perceive. So now, and how you can pick these individuals if they're having actually cannabis use disorders. There must be some, things that would make you think he might be actually abusing the substance, which is the cognitive impairment and the poor performance, whether it's at work or at school or at college level or whatever. There might be some associated psychiatric comorbidities, but the cognitive impairment and the poor performance actually is the thing that would make you think, yes, they might be actually struggling with cannabis use disorders. Okay, so we said that the plant cannabis, as you can see here in front of you, these are the dry flowers and the leaves as well, okay, and the buds as well. So people who are trying to grow this plant, they take the flowers and the leaves and the buds, dry them, okay, and do some preparation steps and mix them with certain solvents in order to get the cannabis brick. This is actually what called is brick because this is easier for transportation and for selling it. Okay. If you would like, or if somebody would like to take the tetrahydrocannabinol, then actually the extraction steps involve too many solvents and a more complicated step in order to get the active substance rather than just the plant itself that's used for smoking. So the exogenous cannabinoids, as we mentioned, they actually have tetrahydrocannabinols. Do we have an indigenous? When we say exogenous, that means we must have an indigenous cannabinoids. Yes, in fact, and we do have. So human body and human brain, subhanallah, has got too many substances that help with appetite regulations, with pain sensation, mood, and memory. And one of them, actually, one group of what we have on board is the indigenous cannabinoids. So we do have indigenous cannabinoids, and that's why we have a specific receptors for them. We have cannabinoid 1 and we have cannabinoid 2 receptors. And the distribution of these receptors is slightly different. Most of the psychoactive or the CNS related effects are mediated by the cannabinoids 1 because it's highly abundant and highly distributed in different regions within the CNS and in the peripheral nervous system as well. Okay. In addition, there are some vascular endothelium cells. They have some of the cannabinoid receptors and some other organs. However, cannabinoids 2, some neurons, they might have cannabinoids 2 receptors, but you can find them actually in immune cells. So that's why maybe in the future we'll discover that, cannabinoids has got some immune modulating effect that so far we do not know, and I cannot tell you about it, because the presence on inflammatory and immune cells, it means maybe there are inflammatory cytokines release or something. Okay, so the indigenous cannabinoids, they work as retrograde neurotransmitters. And I'll explain to you in the slide. But most importantly for you to know is that they are involved in appetite regulation, pain sensation, or they have some analgesic activity and regulating mood and memory as well. Okay, let's go now and see what are these receptors, the cannabinoids 1 and 2. These are basically G protein coupled receptors. And tetrahydrocannabinol, or the active substance, works on these receptors as partial agonists. Okay, when so the original, of course, the original ligand is our own indigenous cannabinoids, and this is working as partial agonist. How cannabinoids or how marijuana or cannabis is abused or used? The standard or the well-known route of administration is by smoking. Okay, you might find it sometimes ingested or taken orally, or again sometimes added to food, or some added to some desserts and cookies. It might be, but people who try the cannabinoids or using cannabinoids through smoking, they will not prefer ingestion, and that is because of some pharmacokinetics related reasons. Why is that? I guess you understand that sometimes if somebody is smoking cannabis or smoking marijuana, then it might be a social occasion where they are gathering with their friends and would like to have, some fun together. Okay, so the fast by which it produces these effects is important for that individual to decide whether he's going to ingest or to smoke. Okay, so when you see the acute effect, if he smokes a cigarette, because they take part of the break that you have seen in the previous slide and they roll it into a cigarette and they smoke it. When the effects, the euphoric effect and relaxation effect, when does it start? It starts within 15 to 30 minutes from the inhalation route or from the cigarette smoking route. Okay, so that's actually quite fast. And the effects are going to be or to reach a maximum concentration within the brain within 1 or 2 hours. And then the half-life is about 4 hours. And this is actually the length of the duration for which the effect of marijuana is going to last for about 4 hours in the human brain or human body. Okay, so however, if you take, for example, the oral route, then the effect will start, a minimum time is 30 minutes, and sometimes it takes 3 hours for that individual to start feeling, happy and relaxed. And the effect might be lasting for 12 hours. So there is a significant lag, of time. It depends on what atmosphere he would like to enjoy, or what atmosphere he would like to smoke marijuana in. Okay, so that's why they would prefer the smoking route rather than ingesting it. What will happen if somebody gets or smokes a cigarette from marijuana? You have the affective effect, something on the mood itself, feeling happy, relaxed. He feel actually there is a feeling of well-being, and the most important actually in something funny is grandiosity. He feels that he's a great person and he's very important, and that's why he's enjoying that feeling. When it comes to sensory, there's increased perception of external stimuli, visual distortion. They see things that are not actually right, especially when with high doses, okay, or with time. And the somatic, they can describe themselves as, feeling their body to be floating, or sometimes feeling their body that it's sinking. Do you see how they, there's actually a disturbance in their cognitive function. And in addition, they will not feel that time is passing around them. And I guess that's why probably they smoke it. And they lose the required attention, reduced coordination and concentration, and they do not remember actually. They will have some memory deficit under the effect of marijuana. Let's see, when we say cannabinoids are retrograde neurotransmitter or receptors, or retrograde actually signaling that they are involved in. So how that happens, what we know so far is that cannabinoids can be, or they can actually modify the signaling in excitatory neurotransmitter as well as inhibitory neurotransmitter. This is actually what I would like to tell you. So there is actually, not because it produces relaxation, that means it does not actually interfere with some excitatory neurotransmitter. So that's actually a complex pharmacology. But what we know so far from research, that they inhibit, with this retrograde signaling, they inhibit the release of GABA as well as glutamate, one inhibitory and one excitatory neurotransmitter. And depends now, the effect that I've just have described to you, it depends on where are these cannabinoid receptors, okay? So some scientists trying to relate where is the distribution and what is the effect on human body in case that these receptors are being stimulated by cannabinoids. If cannabinoid receptors, or if we're talking about cannabinoid 1 in the cerebral cortex and hippocampus, then they say this is actually what mediate the effect on cognitive function and perception. And if it is on basal ganglia or cerebellum, that affects sedation. If it is in cerebral, in the brainstem or spinal cord, then that's going to produce analgesia. Okay, so try to link the anatomy with what happened with cannabinoids, but what we know is what I'm going to tell you right now. Let's say, for example, this is a presynaptic neuron, this is postsynaptic neuron, and there is a neurotransmitter that has been synthesized and stored. And with the action potential comes, it will be released. That different neurotransmitter, whether it's GABA or glutamate, for example, it will go to its postsynaptic receptors and do what it's supposed to be doing. Once that neurotransmitter reaches the postsynaptic neuron, it will stimulate the release of the indigenous cannabinoids from the postsynaptic neuron. So do you see them like these, green squares? They're going actually to travel from the postsynaptic neuron to the presynaptic neuron, and where they have their receptors, which is classically in the brain as CB1 or cannabinoids 1 receptor. Once the indigenous cannabinoids bind with the cannabinoid receptor, they will tell that presynaptic neuron, please stop any more release from that neurotransmitter. Okay, so that's basically what we mean by retrograde signaling. So by which they can modify the release of GABA and glutamate and their balance within the brain to serve in such a way that produces this state of relaxation. Okay, I think you have seen that I put 2 as the, yes.
Could you please repeat the last point?
Type. Here from this slide, this is presynaptic neuron, and it must actually have some neurotransmitter of some sort, okay? What we know from the literature is that GABA and glutamate are involved in cannabinoids pathway, okay? So let's say, for example, this is actually glutamate neurotransmitter, or these are the vesicles where they are storing glutamate or whatever. So there is some neurotransmitter in the presynaptic neuron, and this is postsynaptic neuron. Once some of that neurotransmitter has been released and affects the postsynaptic receptors, it will stimulate the release of endogenous cannabinoids that we have in our body, okay, from the postsynaptic, and they will go to the receptor on the presynaptic neuron. Do you see? This is what I mean. So I'm talking about the endogenous now cannabinoids, okay? And the same thing, tetrahydrocannabinol will do the same. It will go and bind with the cannabinoids receptors. So the cannabinoids released, the endogenous from the post, will go to the pre and bind with the receptor and will tell that neuron reduce the release of that certain neurotransmitter. That's why they can regulate the signaling, okay? That's what I mean. In addition, there are actually some cannabinoids receptors in the ventral tegmental area. And that's why there is actually an element of dopamine release that's being stimulated by cannabinoids, endogenous cannabinoids or exogenous cannabinoids. So that's why you expect some kind of addiction or some kind of dependence that might happen with chronic use. But do you see the number that we have put here next to the title? It's only 2. And if you compare that to the addiction potential with amphetamines and cocaines that we covered in our previous lecture, where the addiction potential is 5 out of 5, then we're talking about something that is less addictive than the other CNS stimulant that we covered. Okay, how bad is the dependence? Okay, the chronic use from cannabinoids or marijuana is defined as more than 1 use per week. Okay, so because some people, they might just actually consume it, social occasions. But if somebody is regularly taking or smoking marijuana, like more than 1 time per week, then he will get to the stage where dependence is there. But do we expect with this relative risk of addiction or this abuse potential too, do you expect the withdrawal effect to be as intense as what happens with amphetamines, for example, or cocaine? No, you would expect that to be mild and short-lived, and with the individual feeling a little bit, irritable, cannot sleep, restless, is not relaxed. He needs actually to smoke a cigarette in order to relax again, but it's not going to be as catastrophic as the effect of the amphetamine cocaine when it comes to withdrawal. There's one mechanism that I would like to just to remind you that if there is a chronic exposure to a certain substance, uh, exposure for the brain to a certain substance, that will lead to downregulation of the receptors that are actually, binding with that substance. And once that individual stops, taking the same or does not access that substance again or cannot smoke marijuana again, during this abstinence period, there will be upregulation of the receptors. Actually, this can sort of, so that individual during withdrawal period, he's dealing with actually upregulated receptors that are available and cannot find the marijuana to bind with. Okay. How much of the chronic users will have cannabis use disorder? It was estimated to be 10%. So 10% will be struggling with cannabis use and they need to seek help. I think I have something on the chat. What is 2 here? Yeah, 2. This is what I've just explained. This is the relative risk of addiction or the relative risk of abuse potential. If my scale, as I told you from last lecture, from 1 to 5, 5 is highly addictive, 1 is non-addictive, then these are 2. Yeah, retrograde, I've explained that. Yes, I am. Yeah, all of the messages here in the text are actually about the mechanism of action that we have just covered. Okay. Now, do we see individuals coming to or seeking medical advice because they're presenting with acute cannabis intoxication? Like what I explained to you with amphetamine and cocaine, when they come with a stroke or with myocardial infarction or hypertensive crisis, they will definitely come to hospital. Somebody will bring them in, okay? But for cannabinoids overdose or intoxication, it's very, very uncommon in adults, okay? Because they know how much they, smoke. Do you see what I mean? But this situation or this, kind of clinical picture has been described in children. Okay, can anybody tell me why would a child, be coming to the emergency room with cannabis intoxication? Can anybody guess? Second hand, that means, yeah, if brownies, yes. So there must be something accidentally. If going to the forest, لا مش لهالدرجة، لأن في process طويلة عريضة، يعني مش حكاية إنه بس يروح الفورست. Okay, so yes, you are right. It could be accidentally, that it has been, a brick of, cannabis or a cigarette or whatever is there, and they start actually to take it orally. I know that, it's the metabolism orally is not as efficient, or bioavailability of cannabinoids orally is 5 to 10. However, the pulmonary bioavailability is about, 10 to 35 higher. But again, he's a little child, and any small dose can create such an issue. But I was actually shocked to learn that some of the case reports in the literature, it means the child was given deliberately, a small piece probably, or if he's an older than 3 years old or something, he can smoke, they can give him. Apparently there are, some, idiots who would like children to fall asleep or to reduce their activity. Can you imagine? An adult who's doing that to a child, they give them just to make them or put them to bed and make them sleep, unfortunately. So now, and unfortunately, regardless. So the limited exposure, if that child has been exposed little to cannabinoids, then you will see some disturbance or change in behavior. He might be sleepy, happy, irritable, any kind of change in behavior that will happen. However, if there are larger doses, then the child cannot actually handle that, and that's going to be very toxic. So they might present with coma, reduced respiration, And sometimes in less than 50% of the cases, they have some seizures because, you know, too many neurotransmitters are involved and causing the CNS, you know, toxic effect. Now, if you are suspicious and you are handling a child or pediatric case with cannabis intoxication, doing a urine drug screen does help. It does help in children because once that child, you find his urine to be testing positive to cannabis or for marijuana, then definitely what you're dealing with, or the most likely, and you're very certain that the coma that you're dealing with is because of, you know, exposure to cannabinoids. We do not have طبعا antidotes, but at least you know what you're dealing with and you do the supportive therapy that you can. But in case that you are working out or you're doing some investigation for an adult who presenting with coma, okay, then you cannot rely on the urine drug screen. Why? Because they say that cannabinoids, you know, the cannabinoids 1 receptors are available in the brain, طبعا, they are widely distributed in the brain. They are available also in fat tissue. So with time, if he's smoking marijuana, you know, like 1 time every week or 1 time every 2 weeks, he's going to accumulate some of the cannabinoid, you know, compounds or metabolites. That he's going to accumulate that in his own fat, okay? And accumulated cannabinoids from the fat, it will move from the fat back to the bloodstream. And if you are going to do a urine drug screen, it will test positive, despite the fact that last cigarette he has smoking, it was 2 weeks back. You see this point? I hope that it is clear to you, because don't rely on the urine drug analysis or screening for cannabinoids in adults, because it might actually indicate that he was smoking like, you know, 10 days back or a few weeks back, because it is accumulating in fat tissue. Let me see if there's any question. Like a storage, exactly. Yes. So they say even in their bloodstream, if you want and detect some metabolites, you will find it in their blood, despite the fact that they have smoking, you know, or did not smoke for a couple of weeks. Okay. Okay, I think these are the questions. Let's go to the slide next. Yeah, now, do you know the status about cannabinoids, whether it's legal or illegal? In most of the countries, it is actually illegal. However, there are some countries that actually they sell marijuana in, you know, in some stores, and they consider it as legal, like Canada and Uruguay. And there are actually, I came to know that 9 states from United States, they consider it legal. And the other countries where somebody is trying to make it legal is because of they are claiming the health benefits of cannabinoids. Yes, we do have health benefits from cannabinoids, and for that reason, we need to know these 3 drugs. Okay, what are the health benefits that can help? Stimulating the appetite, making somebody eat better, reducing the nausea and vomiting. And again, they have been actually found to reduce intraocular pressure, so they can be used in glaucoma. And because of this analgesic effect done by the indigenous cannabinoids, then they might be involved in pain relief. Okay, and yes, there are drugs that has been, you know, developed by pharmaceutical industry, where they are actually containing the active substance, but different chemistry. You know, it's not like exactly the same, you know, tetrahydrocanabinol, cannabinol. We have dronabinol, we have nabilon, and we have nabiximols. This is actually very recent, the nabiximols. Okay, so look at the what I would like you to know is the route of administration and why. This is what you're going to find in up-to-date about their use. Dronabinol is used orally, and it's given as appetite stimulant in AIDS patients. You know, the AIDS patients in advanced stage, they have cachexia, and they do not eat well, and they keep losing weight. So you can stimulate their appetite by giving them 1 tablet before the meal. So like, you know, 2 meals every day, they can take, you know, 2 tablets every day before the meal time. Again, this, you know, suppression of nausea, it can be used as antiemetic, part of the antiemetic protocol before chemotherapy. You can give it before the chemotherapy. Nabilon, again, is used for as an antiemetic before the chemotherapy. And the nabiximols that I told you, which is recent, it's given as buccal spray, and has been found that it relieves neuropathic pain and spasticity an MS patient, multiple sclerosis patient. They have spasticity and pain, so it's easy actually for them to administer this spray, and they can take up to 12 sprays every day, and that's going to relieve the muscle spasticity. Not that to a great extent, but studies have shown that it does help. Okay, so do you expect some addiction potential to occur with these medications? In fact, yes, it does exist for all of them, but we do not actually have, well-controlled studies to show you. And of course, comparing these drugs or addiction potential to marijuana smokers is going to be difficult to test and to prove. But there are some studies that have shown that, yes, somebody who has been taking Nabilon or Dronabinol, they might have some abuse potential for these medications. But the risk is, as I told you, it's 2. All right, so we're done now with
Mary!
Sorry. So we're done with the cannabinoids, which is the main group. Before we go to alcohol, I have here one substance that I would like to explain to you, which is GHB, gamma hydroxybutyric acid. Those who I think just want, please check if you are unmute. Unmute.
I'm
please mute
sorry,
yourself.
doctor. I just muted.
That's fine.
Yeah.
طيب, okay, خير إن شاء الله. Okay, the gamma hydro intraocular pressure, IO, yes. I was just checking the chat. The gamma hydroxybutyric acid, GHB, is a substance that was discovered a long time ago, or it was sort of synthesized in 1960 as a general anesthetic. And then after using it for some time, they have discovered that it actually has got a potent CNS depressant effect with narrow safety margin. Anything that actually can get the patient from being anesthetized to coma is dangerous to use. Okay, for that reason, GHB was stopped actually as being an anesthetic, and it started to be an illicit drug or recreational drug. It is actually one of the medicines that are most often encountered in forensic circumstances or forensic investigation. Why is that? Because they are potent CNS depressant, so they are being classified and used as club drugs or rape drugs. Okay, because these are actually working on GABA, so they are causing this CNS depressant effect. Okay, why they are actually very commonly used in forensic situations or crimes or kidnapping or rape, because they are the tablet itself. When somebody gets GHB, it's supplied as an oral tablet that is quickly dissolving in any beverages. So say, for example, somebody wants to kidnap somebody, then they will just put a tablet in the drink. The thing about it, quickly dissolving, it does not have an odor to change, okay, and does not have a certain color to change. So that victim can drink it very, very easily, and it's very quickly absorbed with the maximum plasma concentration reaching within 20 minutes or 40 minutes, okay? And, the acute effect depends on how much was given to that, victim, okay? Half-life is again short, 30 to 50, but of course, we know that the consequence depends on how much they have been taken. So still, when you see the classification of GHB, you'll find it under the CNS depressant, of course, and used as a club drug. Somebody wants to feel happy and relaxed, and not sort of tense with strangers or with a strange atmosphere, they might take it. But nowadays, the use for being a club drug is declining, and the most commonly used club drugs are you remember what you have taken with the amphetamines, the synthetic cathinones and the bath salts, and these are the ones that, people seems that they wanted to be excited and stimulated when it comes to clubbing. But it will still be there when there is a kind of, kidnapping or rape circumstances. Yes, then this is actually the best, agents to be given to the victim. So initially with acute effect, euphoria, enhanced sensory perception. Amnesia is very important. Why? Because this kind of amnesia is described as antegrade. Antegrade, it means it will happen for the events that are happening after that drug was taken. And this is perfect for somebody who wants to kidnap somebody, because once that victim gains their consciousness back, they will not remember what happened or with whom they were actually, going somewhere, or they do not actually recall the circumstances that helps with the investigation. So larger doses, sedation, this is actually, of course, is required in these circumstances, and coma, and unfortunately sometimes leads to death because of respiratory depression, depending on the dose. Okay. So for that reason, I think everyone knows, it's a very famous advice that all mothers give their, children or daughters, that the feeling of, everybody says that don't drink something that's not sealed. So this is actually, this actually saying is quite right. How can a drug cause a feeling of social closeness? It means that they feel that socially they are comfortable with the people around them. This is what I mean. If somebody is tense and you give something that's causing CNS depressant effect, then they will feel this, the social closeness. They will feel actually relaxed and happy and enjoying the socialization event. But if you give more, then they're going to lose they will get to a stage of sedation and coma. Okay, I hope that it's clear to you. Any other questions? Let me see. Just like alcohol, yes, exactly. Okay. Okay. So let's go and see the next slide. Well, because the rape drugs include a group of medicines. The most important is GHB, and we have other two. Do you see them here? Xanax. Xanax is alprazolam, and what is called as roofies are the flunitrazepam. So the other rape drugs are basically, they belong to the class of benzodiazepines. Okay, with the difference in safety margin. And benzodiazepines are more safe and wide therapeutic index. It's not like GHB. But anyway, these are the common drugs that are being used in order to kidnap or, to cause some, a crime or an assault to someone. So these are college students who tried to invent a nail polish. When it is exposed to these, rape drugs, it's going to change in color. So basically, you can wear that nail polish and you can dip your fingers in that drink, and if it changes, then it's going to indicate that there's something mixed with that drink. These girls, they have actually invented a straw, and that straw, again, it will change in color once it is dipped and stirred within a certain drink that has got something suspicious in it. Okay, more and more trials. This is actually like a small gadget. It detects, again, GHB and other substances, and it can be carried. It's called undercover test. It can be carried. It's very tiny and small and discreet. No one will notice it, and you can dip that in the drink, and it will give you like one line or two lines. One line, I think there is a drug in the drink. 2 lines. طبعا ما أعرف أنا ما شفت بس إنه you can find the instructions on that actually small little test. So and more trials in order to find out if a certain drink has been mixed with something suspicious. Okay, we'll go now to alcohol, Banat. Let me see if there are questions. Oh, yeah, overdose can cause coma. Yes, because as I told you, the safety margin of GHB is dangerous, and it's going to change that victim from, from a sedated state to a respiratory or apneic, and he might die if they do not, of course, rush him or rush her to a hospital. And there are actually some, and post-mortem investigation showed that some of the, victims of certain crimes, they have been given GHB to facilitate the crime. Okay, the alcohol. Alcohol now, according to the WHO, is actually one of the most widely abused substances that is sold legally. The difference between cannabinoids is not legal. It's illegal, and only in certain countries where it's illegal. But alcohol, in some Western countries, it's actually a social drink and a popular drink. But about 5% of those individuals who are consuming alcohol all over the world, they will have alcohol use disorder, and it has been found that, according to WHO, among all deaths reported in the, according to WHO, 5% of them is because of death related to alcohol use or alcohol abuse. Do you see the relative risk is 3? So we're dealing with something less than, the amphetamine and cocaine, but again, it is actually significant. So it might actually, individual might get addicted to alcohol. Now, there are kinetics things that we need to know about alcohol, because alcohol is you can consider alcohol as a drug, and I'm sure that's not covered in any other lecture. That's why I put the pharmacokinetics. If somebody drinks alcohol, this is the main route of administration, is through drinking. It's going to be rapidly absorbed from the gastrointestinal tract, and the site of its best absorption is duodenum and jejunum. For that reason, if you wanted to get to the duodenum and jejunum, that means gastric emptying. If it happens quickly, then it's going to help with alcohol absorption quickly and reaching to the brain quickly. Okay, and if somebody is having a food or a heavy meal and drinking alcohol, he will not actually absorb it as quickly as desired. Okay, so there will be delay in its absorption because the best place is duodenum and jejunum. It undergoes a first pass metabolism by an enzyme called alcohol dehydrogenase, and this alcohol dehydrogenase is present in the stomach as well as in the liver. For that reason, part of the dose that has been taken will be distracted in the stomach before actually even absorption and reaching the liver. So there is actually more than one step in its metabolism. The metabolism of alcohol follows an oxidation reaction where most of it is actually being oxidized and metabolized in the liver. Only a small percentage of alcohol will be remaining in the bloodstream and will be excreted through the lung, and will be excreted in the urine and excreted in the sweat. And this excretion from the lung is the basis behind the breath analyzer test. You know, when they see a driver or something, they want to do a breath analyzer test, then we are actually, or those individuals are depending on that small percentage that's being excreted. The remaining is going to be metabolized in the liver. It does cross blood-brain barrier, okay, quickly to the central nervous system, and the chronic alcohol consumption will induce enzymes responsible for its breakdown, and these enzymes called microsomal ethanol oxidizing system, as I will show you in this slide. This is the metabolism of alcohol. This is ethanol, okay, and it undergoes oxidation reaction by two ways. The first one, this is the main one and the major one, alcohol dehydrogenase. That happens, as I told you, in the stomach, and that happens in the liver as well. Okay, so ethanol, under the effect of alcohol dehydrogenase, which needs some cofactors, it will change ethanol to acetaldehyde. Okay, and from acetaldehyde, we have another enzyme called aldehyde dehydrogenase. It's going to change the acetaldehyde to acetate. And this acetate can be used in too many things. Can be used to synthesize ketone bodies, fatty acids, cholesterol, some steroid compounds in the body. So I can say that it's recycled in the body. Okay. What about this one? This is microsomal ethanol oxidizing system. This is another system for oxidizing ethanol to acetaldehyde. Again, it needs some cofactors. Again, it's there in the liver. But this is the one that's going to be upregulated in chronic alcohol consumption, because, you know, chronic alcohol consumers, they're going to metabolize alcohol more efficiently through increasing the metabolism through this pathway. So this oxidation pathway is known for alcohol. There is a difference. Do you see alcohol dehydrogenase is important in the stomach and in the liver? There is something related to kinetics which would make women more susceptible to the effects of alcohol more than men. They say if you give a man and a woman the same dose of alcohol, then the woman will have higher level in their blood than men. Can anybody guess why or give me an explanation? Anybody can answer this question? Why, when you give a same dose of ethanol or alcohol to man and woman, the woman will have higher level of ethanol or alcohol in her blood? This enzymes, yes, actually, that's good. هذه انت حلا ولا مين ده؟ Okay, the enzymes, they say the alcohol dehydrogenase in the stomach itself, it has reduced, activity in females. So so it's going to less likely to this first pass effect that happens to the alcohol inside the stomach is less in women. So that's why they will have, higher alcohol in their blood circulating. And again, if you remember that, ethanol or alcohol is water soluble, so it actually tends to stay in the bloodstream and in the compartment where there are actually water rather than fat. Okay, so and if you compare, another reason, if you compare the fat content in men and women, women are having more body fat and men are having more body water. So that's why it will be distributed, to the intracellular and extracellular interstitial fluid, intracellular fluid, rather than staying in the bloodstream. So because the compartment for water soluble substances in men is more than in women. Okay, that's a little pharmacokinetics consideration. What will happen if somebody drinks alcohol? It has got a complex pharmacology. I need to speed up. Alcohol enhances the effect of GABA and inhibits glutamate. That's the most important. And if you can see here, there's actually correlation between the alcohol concentration in the blood with the effect, starting from sedation, ending up until coma. Again, the withdrawal, okay, if somebody stops drinking alcohol, you will have this sequence of events. The withdrawal symptoms are going to be more worse with time, depending on how many hours passed since the last drink. And sometimes, على فكرة شباب أو بنات, if you are treating a patient who was admitted to a hospital and he's drinking and he did not give you the real story or the real history from drinking, you might pick them after admission by saying this generalized seizure. I'm telling you from experience because I practice medicine in Western country. So when you take a social history and you ask how much you drink, they will not tell you the truth. They will not tell you that they are dependent on alcohol. And you will find out once, few days after admission. Do you see here? 1 to 2 days, they will start to have generalized seizure, and the whole medical team will go into investigate thoroughly what is the cause of the seizure, and they end up actually with coming to know that this is just a withdrawal syndrome from alcohol. Let's talk about this is the last slide I'd like to explain to you. These are the drugs that we use for alcohol addiction. If somebody is addicted to alcohol and wants to stop drinking, I don't need to tell you how much psychosocial support is important. Sometimes they tell you if that individual is having mild, addiction problem or mild alcohol use disorders, okay, you just actually give them psychosocial support and monitor them, and you put them in, supportive groups, and that might be adequate. But anybody with moderate to severe alcohol use disorders, depending on how much they drink, there's certain question survey they do, then they need medication. The medication are 3: disulfiram, this is an old, naltrexone, and acamprosate. This is the order of their introduction to the market, but not the order of preference. Let's say disulfiram, it's an old drug. We do not prefer it that often. Why? Because disulfiram is an oral medication that's given daily. What it does is that it's going to inhibit aldehyde dehydrogenase. This is the enzyme that will be inhibited by disulfiram. So in case that individual is taking disulfiram daily, let's go that he has gone to the bar or he had a drink, then you will have this metabolism, ethanol to acetaldehyde, and then the metabolism stops because of disulfiram. Acetaldehyde will cause unpleasant reaction. He will make him sick, having flushing, having nausea and vomiting, okay? And then that is supposed to be making him or discouraging him from continuing to drink. But, patients, they will notice. They will know that if they take this medicine, they will have this feeling. If they do not take this medicine or they skip the tablet, they will enjoy their drink. Okay, so that's why disulfiram is not actually the best drug. The best one is naltrexone. Naltrexone, you know that from your your opioid agonist and antagonist. You know that naltrexone is a competitive antagonist at opioid receptors. Okay, why opioid receptors are important here in alcohol addiction? Because it has been found that part of the feeling of alcohol reinforcing, effect to continue to drink is actually attributed to our endogenous opioids. Okay, so this is what is happening in our body. So block these receptors of those endogenous opioids, and the patient will be having successful detoxification, or he will stop drinking gradually. Okay, it's given orally once daily, and sometimes we have long-acting intramuscular injection. The third drug is acamprosate. Acamprosate is GABA agonist, the glutamate antagonist. You see, it does actually what alcohol is doing in the brain. So it will achieve for us the biochemical, environment that, is ideal for, or what alcohol is doing in order to relax and sedate that individual. It's given orally 3 times per day, okay, and then that's it. It restores the balance between them. Now, the important question, which one to start, naltrexone or acamprosate? There are some considerations. Naltrexone, look at the kinetics, once daily or 1 long-acting injection per month. And this one is already 3 times. Do you think which one's better? Definitely the patient would cooperate with taking naltrexone more. That's reason number 1. Reason number 2, naltrexone, they can actually start taking it while actually they are still drinking. Okay, it will make them less tempted to drink. But the studies that we have, because this is a recent drug, the studies that have shown the success of acamprosate were proven on individuals who've stopped already drinking and maintaining sort of, drinking-free periods. So if you ask me, is it actually safe or is it going to work if he is taking acamprosate and drinking as well? I cannot answer this question for you because I need an evidence to support my, conclusion of what my advice. Do you see the difference? This one, he can drink with it. This one, we do not know whether it's going to help or it's going to destroy the plan. Another consideration, this is renal excreted, this is metabolized in the liver. So again, his alcohol, use might actually produce some, liver problems. So your choice depends on the route of elimination of that substance that you have. Okay. This is the last slide that we have from Up to Date. It shows you the mild alcohol use disorder, moderate to severe. The best thing is to start medication. Psychosocial support is there. Naltrexone number 1 or acamprosate. Okay, and they leave, do you see disulfiram is left to the end. They say disulfiram, actually, we can use it if somebody has already stopped drinking and you want to support them to maintain an alcohol, being free from drinking, if they are sort of, cooperating with this approach and they are happy with it. Any questions? Let me see the chat box. And naltrexone is the one, which one? Naltrexone is the one that actually needs liver metabolism, and you needs dose adjustment if he's having alcoholic cirrhosis or something like that. That's why, naltrexone is better. The kinetics are better. It's long acting. It's not like, who will take a tablet 3 times daily and manage, okay? So they will not cause dependence, no. These drugs are not naltrexone, not acamprosate. They will not cause dependence. But, the choice depends on the circumstances, whether naltrexone is better. But al fikra, there's one important contraindication to naltrexone. Say, for example, he's having a pain of some sort and he's taking opioids for that pain. Or that individual is, again, having opioid, addiction, and he's being put on methadone. Can you answer this question for me? You cannot give them an antagonist. Otherwise, it will disrupt, actually, the plan, the pain management plan or the opioid detoxification program that he is actually under. In that case, you are forced actually to go to acamprosate rather than naltrexone. But naltrexone is better in case that he's only having a problem of alcohol addiction and you want to help them. ما في questions أخرى. Excellent. Thank you so much. I hope the lecture was clear to anyone. If you have any questions that come up, please send me an email. Inshallah, I will answer them by email. Do you have the last slide? Actually, the most important thing in here, this is from Up to Date. I have said it in slide 14, which one to choose from these 3. I will not ask you about guidelines. Okay, thank you. Thank you, Hala, so much.
Thank you, Dr. Manal.
Hala, مع السلامة.